everyone, I am Shweta welcoming you to the Medical and Pharmacy Crash Course Division in the Knowledge Club online. Today, I came with second chapter in cardiac pharmacology, that is anti-arrhythmic drugs. Previous heart anatomy and physiology episodes will be required to study pharmacology properly in every step. We know the human heart is both a mechanical and an electrical organ. To peruse the body adequately with blood, the mechanical and electrical component of the heart must work in precise concert with each other. The mechanical component pumps the blood, the electrical component controls the rhythm of the pump. When the mechanical component else, despite a normal rhythm, heart failure can result. Integrative cardiovascular pharmacology, hypertension, ischemic heart disease and heart failure. When the electrical component goes very called an arrhythmia, cardiac myocytes fail to contract in synchronically and effective pumping is compromised. Changes in the membrane potential of cardiac cells directly affect cardiac rhythm, and most antiarrhythmic drugs act by modulating the activity of ion channels in the plasma membrane. Arrhythmias may be due to both improper impulse generation and impulse conduction. These manifest as abnormalities of rate or regularity or as disturbances in the normal sequence of activation of atria and ventricles. About cardiac ion channels, for action potential, cardiac contraction method, cardiac conduction method, cardiac action potential we learned in detail at previous 14 episodes of heart anatomy and physiology. Right? If you missed that lectures, then you can find the link at the description box of this video. Then we have to know the goals of therapy for the anti-arrhythmic drugs. That are: number 1, therapy aims to restore normal pacemaker activity and modify impaired conduction that leads to arrhythmias. Number 2, therapeutic effects are achieved by sodium and calcium channel blockage, prolongation of effective refractory period, or blockage of sympathetic effects on the heart. Many antiarrhythmic drugs affect depolarized tissue to a greater extent than they affect normally polarized tissue. Know more about anti-anginal agents in this episode. Don't skip the lecture, stay tuned up to end. So I am going to start today's episode. Let's start. In contrast to skeletal muscle, which contracts only when it receives a stimulus, the heart contains specialized cells that exhibit automaticity. That is, they can intrinsically generate rhythmic action potential in the absence of external stimuli. These pacemaker cells differ from other myocardial cells in showing a slow, spontaneous depolarization during diastole, phase 4, caused by an inward positive current carried by sodium and calcium ion flows. This depolarization is fastest in the sinoatrial or SA node, the normal initiation site of the action potential, and it decreases throughout the normal conduction pathway through the atrioventricular or AV node to the bundle of His and the Purkinje system. Dysfunction of impulse generation or conduction at any of a number of sites in the heart can cause an abnormality in cardiac rhythm. The arrhythmias are conceptually simple dysfunctions cause abnormalities in impulse formation and conduction in the myocardium. However, in the clinic, arrhythmias patient as a complex family of disorders that show a variety of symptoms. For example, cardiac arrhythmias may cause the heart to beat too slowly, bradycardia, or to beat too rapidly, that is tachycardia, and to beat regularly, sinus tachycardia or sinus bradycardia, or irregularly, atrial fibrillation. The heart cavity from which the arrhythmia originates gives the name to the arrhythmia, atrial tachycardia, for a rapid arrhythmia originating in the atria. Impulses originating from sites other than the SA node or impulses traveling along necessary or extra pathways that lead to different depolarization, that is AV re-entry, Wolff, Parkinson's, White syndrome may also trigger arrhythmias. To make sense of this large group of disorders, it is useful to organize the arrhythmias into groups according to the anatomic side of the abnormalities, the atria, the AV node or the ventricles. Now, what's the causes of arrhythmias? Arrhythmias may be due to both improper impulse generation and impulse conduction. These manifest as abnormalities of rate or regularity or as disturbances in the normal sequence of activation of atria and ventricles. As the native pacemaker of the heart, the SA node has a pivotal role in normal impulse formation. Electrical events that alter SA nodal function or disturb overdrive suppression can lead to impaired impulse formation. Two general mechanisms commonly associated with defective impulse formation are altered automaticity and triggered activity. Number one is the altered automaticity. Some mechanisms that alter automaticity of the SA node are physiology. In particular, the autonomic nervous system often modulates automaticity of the SA nodes as part of a physiologic response. In sympathetic stimulation during exercise, an increased concentration of catecholamines leads to greater beta-adrenergic receptor activation. Activation of beta receptors causes the opening of a greater number of pacemaker channels. A larger pacemaker current is then conducted through these channels and faster phase the 4 depolarization result. Sympathetic stimulation also causes the opening of a greater number of Ca ion channels, means calcium ion channels, and thereby shifts the threshold to more negative potentials. Both of these mechanisms increase heart rate. The parasympathetic vagus nerve affects the SA node by a number of mechanisms that oppose the sympathetic regulation of heart rate. Vagus nerve release of acetylcholine initiates an intracellular signaling cascades, that is, number 1, reduces the pacemaker current by decreasing pacemaker channel opening. Number 2, shifts the threshold to more positive potentials by reducing calcium ion channel opening. And number 3, makes the maximum diastolic potential more negative by increasing potassium channel opening. The SA node, atria and AV node are highly innervated and are thus more sensitive than the ventricular conducting system to the effects of vagal stimulation. Sinus node, means sinus tachycardia and bradycardia, increased vagal activity can impair nodal pacemaker cells by elevating potassium conductance, leading to hyperpolarization. Increased sympathetic activity increases the rate of phase 4 depolarization. Intrinsic disease can produce faulty pacemaker activity. See sinus syndrome. Ectopy fossae are areas within the conduction system that may, in the disease state, develop high rates of intrinsic activity and function as pacemakers. Triggered automaticity results from delayed after polarizations that reach threshold and are capable of initiating an impulse. After depolarizations occur when a normal action potential triggers extra abnormal depolarization, that is, the first normal action potential triggers additional oscillation of membrane potential, which may lead to arrhythmia. There are two types of after depolarization: early after depolarizations and delayed after depolarization. Early after depolarizations are due to opening of L-type calcium channels or fast sodium channels. Delayed after depolarizations are due to intracellular calcium overload and follow spontaneous calcium release from the sarcoplasmic reticulum during prolonged repolarization. This activates the sodium calcium exchange transporter and produces a net depolarizing current. Triggered activity is an uncommon mechanism of arrhythmogenesis but may be responsible for the proarrhythmic. Effect of drugs on automaticity, that is, most of the anti-arrhythmic agents suppress automaticity by blocking either sodium or calcium channels to reduce the ratio of these ions to potassium. This decreases the slope of phase 4, the diastolic depolarization, and or arises the threshold of discharge to a less negative voltage. Such drugs cause the frequency of discharge to decrease, an effect that is more pronounced in cells with ectopic pacemaker activity than in normal cells. Number 2. Abnormal impulse conduction in conduction pathways. Impulses from higher pacemaker centers are normally conducted down pathways that bifurcate to activate the entire ventricular surface. A phenomenon called re-entry can occur if a unidirectional block caused by myocardial injury or a prolonged refractory period results in an abnormal conduction pathway. Re-entry is the most common cause of arrhythmias, and it can occur at any level of the cardiac conduction system. For example, consider a single Purkinje fiber with two conduction pathway to ventricular muscle. An impulse normally travels down both limbs of the conduction path. However, if myocardial injury results in an unidirectional block, the impulse may only be conducted down pathway 1. If the block in pathway 2 is in the forward direction only, the impulse may travel in a retrograde fashion through pathway 2 and re-enter the point of bifurcation. This short circuit pathway results in re-excitation of the ventricular muscle, causing premature contraction or sustained ventricular arrhythmia. Heart blocks may produce bradycardia. Re-entry circus conduction may produce tachycardia. Effects of drugs on conduction abnormalities. The anti-arrhythmic agents prevent re-entry by slowing conduction and or increasing the refractory period, thereby converting a unidirectional block into a bidirectional block. Now, some important types of cardiac arrhythmias. Number 1. Extrasystoles, ES, are premature ectopic beats due to abnormal automaticity or after depolarization arising from an ectopic focus in the atria, AES, AP node, nodal ES, or ventricle, YES. The QR complex in VES is border and abnormal in shape. Number 2. Paroxysmal supraventricular tachycardia, PSVT. Paroxysmal supraventricular tachycardia is sudden onset episodes of atrial tachycardia, that is the rate of 150 to 200 per minute, with 1:1 atrioventricular conduction, is to mostly due to circus movement type of re-entry occurring within or around the AV node or using an accessory pathway between atria and ventricle. That is called Wolff-Parkinson-White syndrome or WPW. Number 3, the atrial flutter, AFL. Atria beat at a rate of 200 to 350 per minute, and there is a physiological 2:1 to 4:1 or higher AV block because AV node cannot transmit impulses faster than 200 per minute. AFL is mostly due to a stable re-entrant circuit in the right atria, but some cases may be due to rapid discharge of an atrial focus. Number 4. Atrial fibrillation, AF. Atrial fibrils are activated asymptotously at a rate of 350 to 550 per minute. Due to electrophysiological inhomogeneity of atrial fibers, associated with grossly irregular and often fast 100 to 160 per minute ventricular response. Atria remain dilated and quiver like a bag of worms. It is the most common chronic arrhythmia. Number 5. Ventricular tachycardia, VT, is a run of 4 or more consecutive ventricular extrasystoles. It may be a sustained or non-sustained arrhythmia and is due either to discharges from an ectopic focus or after depolarization or single site monomorphic or multiple site polymorphic re-entry circuits. Number 6. Torsades de pointes. In French, it's called twisting of points. Is a life-threatening form of polymorphic VT with rapid QRS complexes, which appears as undulating wave around the baseline in the ECG. Hypokalemia and hypomagnesemia predispose to torsade points, which is generally associated with long QT intervals. Number 7. Ventricular fibrillation, VF, is grossly irregular, rapid and functionated activation of ventricles resulting in incoordinated contraction of its fibers with loss of pumping function. It is fatal unless reverted within 2 to 5 minutes. VF is the most common cause of sudden cardiac death. Number 8. Atrioventricular AV block is due to depression of impulse conduction through the AV node and bundle of his, mostly due to vagal influence or ischemia. First degree AV block slowed conduction resulting in prolonged PR interval greater than 0.21 second. Second degree AV block, some supraventricular complexes are not conducted, that is drop beats. Third degree AV block of supraventricular complexes are conducted. Ventricle generates its own impulse, also called complete heart block. So now come to the main point. What's the classes of anti-arrhythmic agents? Anti-arrhythmic agents have traditionally been organized into 4 classes based on their mechanism of action. Number 1. Class 1 anti-arrhythmic are sodium channel blockers. Class 1 drugs block fast sodium channels, thereby reducing the rate of phase 0 depolarization, prolonging the effective refractory period, increasing the threshold of excitability and reducing phase 4 depolarization. These drugs also have local anesthetic properties. These class 1 arrhythmic drugs have 3 types. That is, the class 1A drugs prolong the refractory period and slow conduction. Type 2, that is class 1B agents, shorten the duration of the refractory period. And type 3, the classic 1C drugs, slow conduction. Second type of antiarrhythmic drugs, that is class 2. Antiarrhythmics are beta-adrenergic receptor antagonists. Class 2 drugs are beta-adrenoceptor antagonists including propranolol, which act by reducing sympathetic stimulation. They inhibit phase 4 depolarization, depress automaticity, prolong AV conduction and decrease heart rate, except for agents that have symptomimetic activity and contractility. Third type of class is class 3. Antiarrhythmics are potassium channel blockers. Class 3 drugs prolong action potential, duration and effective refractory period. These drugs act by interfering with outward potassium currents or slow inward sodium currents. And last type of class is class 4. Antiarrhythmics are calcium channel blockers. Class 4 drugs selectively block L-type calcium channels. These drugs prolong nodal conduction and effective refractory period and have predominant action in nodal tissues. It is important to realize, however, that many antiarrhythmic agents are not entirely selective blockers of sodium, potassium or calcium channels. Rather, many of these agents block more than one channel type. This section presents some useful definition of common cardiac electrical disturbances and describes the mechanism of drug action or each class of antiarrhythmic agents. We have to know in detail about these 4 classes of antiarrhythmic drugs. I will discuss, but not for today. I will come at next episode with class 1 type antiarrhythmic drugs. So, we learned today about arrhythmia, general mechanism of action of antiarrhythmic drugs, classification of antiarrhythmic drugs, etc. in pharmacological relevance. Revise the all episodes on heart thoroughly. I made it step by step accordingly. Here the all previous episodes list on heart anatomy and physiology chapter and cardiac pharmacology chapter. You will get all links at the discussion part of this video or you can visit our channel. Before ending today's episode, if you like this video, please like, share and comment freely. Don't forget to subscribe our channel. If you already subscribed, then thanks a lot. And after subscribing our channel, please click on the bell button for getting the regular update. I am coming with another episodes very shortly. Till then, goodbye.